So I'm Greg Archual. I'm the Administrator of Ohio State, so I'm here on behalf of AAAM to present our annual survey results for FY21. So I have no conflicts of interest to disclose. So first I'll start off with the benchmark committee. Here's the members of the benchmark committee. We work hard. We have a call once a month. In addition to that, we meet every summer for a day and a half to rip up the survey and fix definitions and do all kinds of stuff. So the committee's made up of both AAAM administrator members and chair members. So our survey covers the tripartite mission, and the benchmark survey this past year, what we added was the COVID survey, because we wanted to see what kind of impact that had on our operations, some wellness questions and some other things. I'm not going to go through all these again because I have a limited amount of time, but the COVID survey data will be the first half of the presentation. At the bottom there, Roundtable Analytics, they are the vendor who host our benchmark survey, and they have a nice tool that we're able to use to glean a lot of the data. So the benchmark survey, the COVID survey, we decided to start collecting the data monthly for this, and these are the 31 institutions that participated and were able to submit 2 years worth of data at the end. So we tried to keep the data elements we wanted really simplistic, so it wouldn't be difficult to get this data. And geographically, those representation. So it's cross country, not as many in the West, mainly Northeast, Midwest, South. So first, when COVID hit, when summer came, June of 20, we kind of thought we might have been through the pandemic. So we decided to collect data from January, so we had a baseline to start with the pre-pandemic through June of 20. So we collected that data, monthly data again. And then we decided to get a better benchmark, a better starting point, we decided to collect calendar year 2019 data each month. So that way when we wanted to compare the COVID data, we had more than just 1 month to compare to. Then when we had the second wave, we decided, well, let's just collect all the way through December of 21. So what I'm going to show you is basically 2 calendar years worth of data reflecting COVID operations, so January 19 through December of 21. So what it'll look like. So here is all the individual institutions, and then we have the median line for everyone. So you can see before COVID, we were averaging about 1,500 visits. Then you can see when the peak, when we really bottomed out, we were seeing about 3,300. As recovery started, we got up to 5,100, up to 53, 55, 66, and then the last 6 months of 2021, we were actually up to 5,708, so not quite up to our pre-pandemic levels. Regionally, they all had pretty much the same pattern. February shows a little bit of dip each again because these are total numbers, so February is a shorter month, obviously less amount of days. January, right before the pandemic, excuse me, our volumes were going up. We were having a spike. It looked like we were going to beat our previous year's numbers. And then there it shows June as recovery started up again when we thought we were through the first wave. But then the second wave hit, another dip, and then it started to go back up again. So the big difference here, if you look, 15% was the biggest difference in the regions, the South being the lowest. And then once we hit December 21, the South was still lower, so they seem to be recovering slower than the other regions. So breaking down the patients, our discharge patients, again, pre-COVID, we were about 3,600. Again, at the dearth, we were around 2,100, slowly recovered up to 33, and then we got to about 86% of our previous volume, and then the last 6 months of 21, we got up to about 95% of pre-COVID. So we didn't quite get back to pre-COVID. But hospitalizations, again, they dipped just like treat and released, but they bounced back up and we're actually ahead of pre-COVID. So by the end of last 6 months of last year again, we were actually ahead of the pre-COVID number or right at the pre-COVID number. EMS arrivals kind of did a similar thing. They dipped, but then when they did bounce back, they eventually did get to be above the pre-COVID volume for the last 6 months of 21. So if you look at the EMS volume, since the numbers actually increased a little bit and the number of visits went down, our actual percentage of EMS patients of our total visits actually went up from 26 to 28%. But the number of admissions of our EMS patients really didn't change, still at 44%. So acuity of the patients, I think we all know we had less low acuity patients and maybe higher higher acuity patients. So this shows the dip again. Then level 4s, you can see percentage of our patients, when the pandemic hit, they dropped. Level 2s obviously went up. Interesting, as we scale out the whole 2 years worth of data for level 3s, they are also trending down. So then if we look at the ratio of our high acuity patients, our level 1 and 2s, to our level 4s and 5s. Pre-pandemic, for every 1 and 2 patient we have 1, 4, and 5. The peak of the pandemic, it was 3 level 1 and 2s for every 4 and 5. And then it's slowly been trickling back to 2.8, 2.5 for the 12 months. Then the last 6 months, it's gone down to 2.3. So might have back to a leveling effect and getting back to where we were. Without being seen, again, pre-pandemic was pretty consistent, low 2s to a little bit below 4. Pandemic hit, 0.6, so left out being seen obviously wasn't a factor then. Started to recover, went back up to 2.3, kind of before where we were, so we were kind of hovering where we were for the next 6 months or so. And then we kind of shot up. April, it went up to 3.6, August 6.4, December 5.6. So you can see left out being seen line is going up. So again, yes?
Sorry, when you look at left without being seen,
Mm-hmm.
what do you include there? Because does it count somebody who might go from the department after a physician evaluation or anything?
No, that's not left out being seen. Anybody who leaves before they're seen by a provider. Okay, so then for boarding, again, 8,400 roughly pre-pandemic. Of course, boarding pretty much went away during the pandemic. Maybe that's one way to fix boarding, but not a good way. But we kind of went back up to our normal number, and then the last 6 months of 21, it just ballooned and went way up, which I'm sure those of you who are treating patients feel that pain. So again, our volumes are slightly down. Hospitalizations are kind of even. And I'll show you some inpatient data in the next slides, but patients are staying in the hospital longer. For professional fee charges, again, kind of relates to acuity, right? We were about 81% pre-pandemic, bumped up again because of that level 4s going down and 2s going up. And now it's kind of leveled off. We're kind of back to where we were pre-pandemic as far as the percent that are level 4 and 5s in critical care charges. Another way to show the visits over the 3 years. And the big thing about this is, for example, in 21, we saw 4,600 less than we saw in 19, and then we actually saw more than we saw in 20. But if we take the volume we lost from 2019 and put a dollar figure to it, to our revenue, our collections, it's about $650,000 we've lost in collections from losing those patients.
Per emergency department?
Yeah, as for this 31 that participated, correct. So we're better than we were last year during the pandemic, obviously, but not quite back to the pre-COVID volumes. So that's kind of our COVID survey. So I'm going to move on now and show you our normal annual survey that we do. Again, the COVID survey we did was calendar year. Our annual benchmarking survey here is fiscal year. So we have fiscal year 19 was what we're calling our last normal year. So that again was July 18 to June of 19. Then fiscal year 20 was kind of the mix. So when you see that data, it's going to look a little weird because the first 8 months were normal. And our volumes are actually trending higher than 19, but then the last 4 months, the bottom just fell out. But we didn't do any adjusting to the data we collected. We kept all of our standard definitions, collected our data all the same way. So you'll see that reflected in some of the numbers. And then 21 last year was from June of 20 to July of 21, and calling kind of potentially our new normal. So as far as number of participants, we were very happy during the last 3 years with the pandemic going on that we stayed pretty consistent at around 90. We were happy with that. You can see in the past, we were getting close to 100, and that was our stretch goal, and we're kind of, now that hopefully we're getting back to more normal operations, we're going to shoot for that again. Again, geographically, a little more evenly distributed than the COVID survey was throughout the country. Northeast is kind of the biggest participants. And again, if you take the whole grouping, this is kind of what they look like in total. So about 57% are private, 3/4 are level 1 trauma centers. And as far as inpatients go, the average is about 637 beds in the hospital that you have. Mean length of stay for fiscal year 21 was 7.79. For fiscal year 20, it was 6.6. So we had a 1.19 increase in length of stay for inpatients. So it's a 15% increase kind of goes back to why did boarding bump up, right? Patients are in there longer. So here's kind of the median numbers when we take all 88 that participated here. Again, 656 beds, and the visits were 56,000. But you see, we kind of had a big range. We have some smaller EDs and obviously some large EDs in here. So again, comparing 19, 20, and 21, the bed sizes kind of stayed the same. Licensed beds, we have about 60 in the ED. Percent of beds that we consider our main pod or our main part of the department is about 70%. But really the big factor here, look at the visits. So as you can see, in 19, we had 64,000 visits, had a 7% drop in 20, and then another 5.4% drop in 21. So if you compare 19 to 21, it's a 12.5% drop, or 22 patients less each day that we're seeing in the emergency department. So where did this happen? In a treat and release population. So we went from 42,000 in 19 down to 35,000 in 21. And you see the hospitalized patients pretty much stayed flat. So all the impact was on treat and release patients. EMS arrivals, again, they kind of fell down a little bit, but the actual percentage, again, because the total volume went down, actually bumped up. And even the percent admitted bumped up to 45%. One thing that surprised us when we were looking at the data was the peds volume really bottomed out. They went from 24,000 to like 20,000 visits. So those of you with peds EDs probably really felt that. So the trend on the volume, again, on the medians, we were doing well up to 17, and then we've started to slowly trickle down and really took a hit, obviously, with what's going on. So based on, again, the COVID survey, we have actually 6 months worth of data for those 31 institutions for FY22. So we kind of looked at the numbers of visits they were seeing in the first 6 months of this year and then extrapolated that out at what we think FY22 might look like. And it looks like we might bounce back up and actually have an increase in volume this fiscal year 22. So we're kind of anxious to see when this year ends what our data looks like. As far as length of stay goes, creeping up. The biggest increase was in the admitted ones. Again, it kind of ties back to the boarding we were talking about. So if you take what's making up, why are the length of stay increasing? So we looked at bed to decision. So this is the time when our providers have the patient under their care until they make the decision to either admit or treat or released. So for these patients, for admitted patients, we're actually better than 2020 by a half hour. So if we take those half hour times the number of admitted patients, we're actually increased our bed capacity by 3 beds. So yay for us. Unfortunately, boarding went up by 90 minutes per patient. So again, if we take those patients times the volume, that's 3 beds. So we were a wash. We gained beds because we did better, and then we lost them because of the boarding. So boarding time, again, 80,000 hours in 19. In 20, it's 86,000, which doesn't sound like a big increase. But again, you got to remember the first 8 months were normal months, and the last 4 months were COVID months with not much boarding. So that number in 20 without COVID would have been a lot higher probably. And as you can see in 21, it's really bumped up. So what's that equate to? In 19, that was 9 beds that we had dedicated every day to take care of boarded patients. In 20, it was 10 beds. In 21, it was 13 beds. So again, based off of the COVID survey, we have 6 months worth of data. We tried to extrapolate what would that be out for the whole year if it stayed at the same pace. And it would be 16 beds in FY22 that we're dedicating to take care of inpatients every day. So what's happening with boarding? So we've been tracking this since 15 on this graph. So you can see these trends are going the wrong way. Less than 4 hours. Back in 16, that was 75% of our boarded patients were in there less than 4 hours. Last year, only half of them were there less than 4 hours. The big increase, greater than 8 hours, right? We went from only 7% to now more than a quarter of our patients that are boarded are in our department more than 8 hours. So they're in our department. Who takes care of these patients? So 67% of this group reported that for non-ICU patients, the inpatient care team comes out to take care of the patient. And for ICU patients, about 50% have inpatient teams come down and take care of them. Interestingly, only about a third of us get any kind of financial support to suck up this extra work and take care of these patients. Ancillary resources, these numbers don't change a lot from year to year, so we kind of have to look at a a longitudinal look at these going back to 16. So as you can see, CT utilization is creeping up, as well as lab. And we found this interesting when we started tracking 18. Discharge consults are going up, went from 7, now they're up to 8.5%. So again, just something we kind of keep an eye on. So one thing the committee's been kicking around, Jim Shulin, who's led our committee for years, always kept talking about he wanted to try to develop a complexity index. We know we have our case mix index for admitted patients, but that's only on our admitted. We're like, what does our total population look like? So we worked with Roundtable, picked out these 5 data elements and said, here, you've got years worth of data, play with it, see if you can come up with an index number based on these 5 elements. So they put that together and they came up with this complexity index, and it kind of played out how we thought it would. Primary academic is higher than academic affiliate, higher than community. And the data looked consistent from year to year. So we thought this was kind of neat. And then Vizient kind of heard we were looking at this. And as we said, Vizient does come out with the case mix index of our admitted patients. But a lot of our members are members of Vizient, so we've actually started having monthly calls with them to try to work more on this complexity index that we want to develop, because they have most of our data at the patient level. So they are actually pulling in tons of variables now, and we're trying to build this complexity index. So we meet, like I said, with them every month. So hopefully in future SAM meetings, we can keep presenting and where we're moving on with them. So it's good to have somebody with Vizient's horsepower behind us with data and with the statistical expertise. So more to come on that, hopefully. So again, wrap it up here just to show what our academic departments look like compared to community, freestanding pediatrics, obviously. We have the more arrivals, we have bigger departments, we have a bigger admit rate, and by our first acuity mix that we had, or try that we did on our index, we have sicker patients. The other thing we look at is value-added time. So value-added time is described as from the time the patient gets into a bed to the provider is done and made a decision what they want to do with that. Everything that happens before that or after that has nothing to do with taking care of the patient or adding to their patient care, right? Waiting for a room, or waiting for a bed upstairs has nothing to do with value added. So for discharge patients, about 71% of their time is actual value-added time. But unfortunately, in our academic medical centers, for admitted patients, only 37% of the time they spend in our department is actually value-added time. So again, why is that? Again, we looked at this over years. So again, the percent of time value-added, you see treated or discharged, it's very consistent, right around 70%. But if you look at admitted, you see it's been slowly trickling down. And if you look at last year, it's down to only 38% of the admitted patient's time is value-added time. So again, why is that? Boarding keeps going up. So quickly, charging data. If you look at the bottom there, our collections per visit, fortunately, does keep going up every year. And hopefully we'll keep on that progress. This slide here just shows what the median charges were for each department. It has $7.7 million, again, $140 collection. So what Jim did with this is he then looked at what's the variance from 19 and 20. So if you look at, if you compare 21 to what 19's numbers were, it was like $1.1 million less in charges. And in 20, it was like almost $500,000. So again, that loss in volume translates to a lot of dollars to everyone's budgets, right? So it's 1.1 million in charges and $500,000 in charges, comparing the 2 years. So what do the codes look like? Again, this kind of goes back to what we talked about, higher acuity patients coming in, right? Level 3s are dropping, level 4s and 5s and critical care are going up. So 83% of our charges right now are level 3s, level 4, 5 and critical care. And 90% of all of our charges come from E&M codes versus like procedures. The payer mix isn't doing a lot of changes. Medicare seems to be creeping up, but the rest of them kind of staying consistent. And last thing here is faculty productivity. Overall, if you just throw all the faculty together, they produce about 5.3 RVUs per hour. And about, if you're strictly a clinical excellence person, about 9,500 clinical RVUs. And it seems to be as you move on in rank, you become more productive as far as RVUs per hour go. And with that, that's my last slide. I'm sorry I went fast, but we have a lot of data. So questions, yes?
So, do you count in the total ED volume, do you count them without being seen?
Yeah, we count without being seen. Yes?
So, it's 2 questions.
Yes.
Number 1, for the level without being seen, do you know if that number is rising? And it seems it would be given boarding. And then B, do you break it out by provider type? Do you have any information on
We do have information on APPs. We are talking about trying to track at the RVU level. So we have their hours. Help me out, some of you guys are. Salaries, yeah. We do have a lot of data. Again, if you guys want to see the data, your administrator or just reach out to me. We've got a lot of data here. I was trying to show a summary. We do have APP data, though. Maybe not at, I'm not sure what level you want to see it at, but we have like RVs per hour, all that kind of stuff. Any other questions? Thanks. Sorry, no, I had a lot to rush through. So, all right. Thanks, everybody.